Welcome back to Deep Dive, everyone. Especially thinking about our future healthcare heroes today, because we're tackling a really critical topic, substance-related and addictive disorders.
That's right. We're digging into a key chapter from Varkarolus today. And, the goal isn't just textbook knowledge. We want to break down the jargon, get to the core insights you'll actually use, both for your exams and for real-world patient care.
Exactly. Think of this as your shortcut, kind of, to understanding the essentials assessment, communication, the disorders themselves, meds, interventions, all viewed through this substance use lens. We'll even, walk through some case scenarios connected to NCLEX stuff.
And when we mention things like assessment tools or charts from the book, we'll describe them clearly so you can picture it, even without the visual. We really want to emphasize that holistic, patient-centered approach. Think about ethics, culture, safety, all of it.
Okay, let's dive in. This is a big, challenging area, and we're starting from the understanding that addiction isn't, well, it's not a choice. It's a complex brain disease. So to really get started, maybe we should define our terms. When we say substance use disorder, what are we actually talking about?
Good place to start. Fundamentally, these are complex brain diseases. The key features are craving, seeking, and using the substance even when there are negative consequences. And it's important, the DSM-5, the diagnostic manual,
Right.
it moved away from older terms like substance abuse or dependence. Now it's this single category substance use disorder, more of a spectrum idea.
Okay, so beyond the name change, what are the core features a nurse really needs to look for, the practical signs?
Yeah, they fall into about four main groups. First, there's impaired control, like using more than intended or not being able to cut down. Second, social impairment problems at work, school, home because of the use. Third is risky use, using in dangerous situations. And fourth, the physical side, intoxication, tolerance, and withdrawal.
Okay, let's break those down. Intoxication, tolerance, withdrawal, addiction itself. Crucial terms.
Absolutely. So intoxication, that's simply being under the influence, right? Using to excess. The effects vary wildly depending on the substance.
Like being high.
Exactly. Then tolerance. This is key. It's when the person needs more of the drug to get the same effect, or the same amount just doesn't work like it used to. Their body's adapted.
Right, and withdrawal.
That's the body's reaction when the substance is stopped or cut back. It's a set of physiological symptoms specific to each drug, and they can range from just uncomfortable to honestly life-threatening.
Okay, and then addiction is the umbrella term.
Yes. Addiction is the chronic disease involving the brain's reward circuits, motivation, memory. It's a dysregulation. It leads to those cycles of relapse and remission, and without treatment, it often leads to serious disability or even premature death.
So these are actual brain changes we're talking about, not just behavior.
Absolutely. Yeah, continuous use literally changes brain structure and function, especially those executive function circuits.
The decision-making parts.
Exactly. Self-control, judgment. The parts of the brain that help you weigh consequences and make good choices, they're physically altered. And the neurobiology is fascinating, involves dopamine, GABA, opioid systems, especially dopamine neurons in the VTA, the ventral tegmental area. That's the core of the brain's reward sensation.
Wow. So when we look at the scope, how widespread is this? What do the numbers tell us?
Well, the National Survey on Drug Use and Health gives us the best picture. Back in 2014, data showed over 21 million people in the U.S., that's nearly 9% of the population, had a substance use disorder.
9%, that's huge.
It is. And we're seeing concerning trends like rising illicit drug use. Marijuana is up among those 12 and older, and a big jump in non-medical use of prescription pain relievers.
And that leads to the government's response, right? The focus on prescription drug misuse.
Yes, it's a massive public health concern. Over 120 people dying every day from overdoses in the U.S. And controlled prescription drugs actually cause more overdose deaths than cocaine and heroin combined.
How does that happen?
A big factor is unused prescriptions getting into the wrong hands, maybe diverted from family or friends. And sometimes when prescription opioids become too expensive or hard to get, it can lead people towards cheaper, more available heroin. It's a tragic pathway.
So initiatives like the DEA's Drug Take-Back Day are really important then.
Critically important. Safe disposal is key.
And how are these drugs classified legally in terms of risk?
The DEA uses a schedule system, I through V. Schedule I drugs, like heroin or LSD, have high abuse potential and no accepted medical use. Schedule V, on the other end, have very limited narcotic amounts for specific things, like some cough medicines and low risk. Understanding the schedule tells you a lot about the drug's potential danger.
So for a nurse listening, why do these stats matter day to day?
Because of comorbidity. That's the big thing. Substance use disorders rarely travel alone.
Meaning they happen alongside other mental health issues.
Exactly. That same 2014 survey found almost 8 million people had both a substance use disorder and a mental disorder, like major depression, bipolar, anxiety. And when you have both, symptoms are usually more severe, there are more crises, and treatment often needs to be longer and more integrated. You're almost always treating more than one thing.
That really changes the approach. So what puts someone at risk in the first place? Is it genetics? Environment?
It's definitely a mix. There's a strong biological piece. Genetics account for maybe 40 to 60% of the risk for alcohol use disorder. Twin studies show heritability for things like cannabis, cocaine, opiates, too, maybe even 70, 80% for those last two.
Wow.
Yeah. And neurochemically, imbalances in those opioid, dopamine, GABA systems we mentioned play a role. But environment is huge too. Chronic stress, poverty, poor parental supervision, peer pressure, especially for teens, and sociocultural factors, community norms, cultural views on drinking, they all shape patterns of use. It's complex.
Okay, we got the foundation. Let's get into the specifics now. Different substances, what intoxication and withdrawal look like, how they're treated, what a nurse would actually see.
Right. Let's run through some common ones. We can start with caffeine. Probably the most widely used psychoactive substance globally.
My morning necessity.
Exactly. While it's not an official use disorder in the DSM-5, you can definitely have intoxication, restlessness, excitement, rambling speech, flushed face, rapid heartbeat, maybe GI upset. And withdrawal is real too, headache, drowsiness, feeling irritable.
Makes sense. What about cannabis or marijuana?
Okay, most widely used illicit drug. Intoxication often means heightened senses, brighter colors, time feels slower. Higher doses might cause depersonalization, feeling detached. Physical signs, red eyes, increased appetite, the munchies, dry mouth, maybe some tachycardia.
Yeah, withdrawal.
Withdrawal usually kicks in within a week of stopping. People feel irritable, anxious, have trouble sleeping, lose their appetite. Sometimes physical stuff too, like stomach pain or shakiness. Treatment is mostly about abstinence and support therapy, maybe short-term anti-anxiety meds for rough patches.
Okay. What about hallucinogens? LSD, PCP, ketamine?
Right. These generally don't have medical uses and cause pretty profound reality disturbances. Intoxication can look like paranoia, poor judgment, really intense perceptions, feeling detached from yourself, depersonalization, or reality derealization. Illusions, hallucinations, synesthesia, like hearing colors are common.
Right.
Physically, dilated pupils, fast heart rate, sweating.
How do you manage that?
Often just talking the patient down in a calm, safe environment works. But for severe agitation or cytosis, antipsychotics or benzodiazepines might be needed.
You mentioned PCP earlier. I've heard PCP intoxication is a different beast altogether, a real medical emergency.
It absolutely is. Patients on PCP can become incredibly belligerent, assaultive, totally unpredictable. You'll see things like nystagmus, those involuntary eye movements, high blood pressure, they might not feel pain normally, muscle rigidity. Seizures and hyperthermia, dangerously high body temp, are serious risks.
So talking down doesn't work.
No, not with PCP. Safety is paramount. They often require restraint, calming meds like benzos, and if they have severe hyperthermia, active cooling measures. And while there isn't a formal withdrawal syndrome, some people experience hallucinogen persisting perception disorders, flashbacks long after use, which is really distressing.
Scary stuff. What about inhalants?
These are volatile substances in common household products, glue, paint, fuels. Use is most common in kids aged 12-17. The big immediate danger is sudden sniffing death from cardiac arrhythmias.
Oh, wow.
Yeah. Intoxication might bring euphoria or disinhibition, but higher doses can cause hallucinations, body image distortions, serious outcomes like coma, heart rhythm issues, or psychosis can happen. Early recognition is key.
Okay, let's talk about opioids. Heroin, prescription painkillers.
Yeah.
This is a huge issue.
Huge. It's a chronic relapsing disorder, intense cravings, intoxication signs, psychomotor retardation, slowed movements, drowsiness, slurred speech, constricted or pinpoint pupils. It can progress to coma and respiratory depression.
And the withdrawal. Cold turkey.
That's the term, yeah. It's miserable. Mood dysphoria, nausea, vomiting, diarrhea, muscle aches, fever, chills, watery eyes, runny nose, yawning, and piloerection goosebumps. For heroin or morphine, it usually starts 6 to 8 hours after the last dose, peaks around day 2 or 3.
And overdose is the lethal risk here.
Yes, primarily due to respiratory arrest, they stop breathing. Key signs:
Well.
unresponsive, very slow breathing, Coma, pinpoint pupils, low body temp, maybe bluish skin.
Treatment.
Immediate. Support breathing, maybe ventilation. And administer naloxone Narcan. It's an opioid antagonist, reverses the effects quickly. But importantly, naloxone wears off faster than many opioids, so the person can slip back into overdoses. Repeated doses and close monitoring are critical.
You mentioned earlier the link between prescription opioid misuse in youth and later heroin use. Big implications for nursing, right?
Massive. Research clearly shows that link, especially non-medical use starting as young as 10, 12. It highlights our role in patient education, teaching families to safeguard medications, lock them up, dispose of them properly. Recognizing these can be gateway drugs for vulnerable kids.
And treatment for ongoing opioid use disorder.
It's multifaceted. Therapy individual, family, support groups like Narcotics Anonymous, NA, and medication-assisted treatment, MAT, is vital. Options include methadone, a long-acting synthetic opioid that reduces withdrawal and cravings, blocks the high from other opioids. Buprenorphine, a partial opioid agonist, has weaker effects, helps with withdrawal, often combined with naloxone. And naltrexone, an opioid antagonist, blocks the euphoric effects if someone relapses, helps prevent continued use.
Okay. How about sedatives, hypnotics, anxiolytics, benzos, barbiturates?
Right. Intoxication looks like slurred speech, poor coordination, unsteady walking, impaired thinking. Coma is a risk with high doses. Overdose management might involve gastric lavage, activated charcoal. The crucial point for nursing with this class is withdrawal.
Why is that?
Because abrupt stopping can cause severe rebound hyperactivity tremors, insomnia, anxiety, and potentially life-threatening grand mal seizures. Withdrawal must be managed with a gradual taper of the medication. You never just stop these colds.
Got it. Stimulants next. Amphetamines, cocaine.
Yep. Produce euphoria, tons of energy, intoxication,
Yeah.
feeling superhuman, very sociable, but also hypervigilant, anxious, maybe paranoid or angry physically. Chest pain, heart arrhythmias, high or low blood pressure, dilated pupils.
And withdrawal.
Often called the crash. Tiredness, vivid unpleasant dreams, insomnia or sleeping too much, increased appetite. The most serious risk here is severe depression and suicidal thoughts during withdrawal. Amphetamine withdrawal might need inpatient care for safety. Cocaine withdrawal isn't usually physiologically dangerous, like alcohol or sedative withdrawal, but the intense craving can be overwhelming and might require hospitalization to prevent relapse.
What about tobacco?
Rapid dependence, characterized by craving, persistent use despite harm, tolerance. Withdrawal is really unpleasant. Irritability, anxiety, depression, difficulty concentrating, restlessness, increased appetite. Treatment involves behavioral therapy, maybe hypnosis, nicotine replacement, gum, patches, lozenges, and non-nicotine meds like bupropion or varenicline. Nurses play a big role in counseling and supporting cessation efforts.
And finally, you mentioned gambling disorder. Not a substance, but an addiction.
Exactly. It's a process or behavioral addiction. Shares many features. Preoccupation with gambling, needing to gamble with increasing amounts of money to get excitement, restlessness, or irritability when trying to cut back, lying to hide it, jeopardizing relationships or jobs, sometimes illegal acts to fund it. Treatment often involves Gamblers Anonymous, GA, a 12-step program, therapy, and sometimes meds like SSRIs or naltrexone have shown some benefit.
Okay, that's a great overview of the specific substances. Now let's shift to the nursing process itself. How do nurses actually apply this knowledge in practice, step by step?
Right. This is where you put it all together. It starts with screening. Early identification is key. We often use the Esperant model. Screening, brief intervention, and referral to treatment.
Write that down.
Sure. Screening is using validated tools to quickly assess risk level and identify if there's a problem. Brief intervention is having a short, focused conversation to raise awareness and motivate the patient towards change. And referral to treatment is connecting them with appropriate specialized care if needed.
Can you give an example of a screening tool we might use? Like, describe what asking those questions feels like.
Absolutely. A common one is the AUDIT, the Alcohol Use Disorders Identification Test. You'd be asking questions like, how often do you have a drink containing alcohol? Or, how often during the last year have you failed to do what was normally expected from you because of drinking? Or maybe, how often during the last year have you had 6 or more drinks on one occasion? The key is your approach, completely non-judgmental, matter of fact. Your tone conveys safety. Other tools you might see are CAGE, CAGE-AID, TACE.
Okay, so after screening.
Then comes a full assessment. This is more in-depth, ideally done by an addiction specialist, but nurses gather a lot of this data too. You look at patterns of use, consequences, co-occurring mental health issues, trauma history, family history of addiction, but also the patient's strengths, support systems, and their readiness and motivation for change.
Family assessment is part of that.
Definitely. Understanding the family dynamics is crucial. You might hear the term codependence. This is where family members often develop patterns of, well, overly responsible behavior. They might enable the substance use unintentionally, define their own self-worth by fixing the other person, often neglecting their own needs in the process. It's complex.
And what about assessing ourselves as nurses?
Critically important. Self-assessment. We have to look at our own beliefs, attitudes, maybe biases about addiction and substance use. Are we feeling judgmental, frustrated, overly responsible? Recognizing our own countertransference is essential for providing objective, empathetic, patient-centered care. And interestingly, nurses as a group are at higher risk for substance use issues themselves.
Really?
Yeah, the stress, access, it's a known issue. That's why many state boards of nursing have non-punitive peer assistance programs. They help nurses get treatment and monitoring while protecting patient safety. It's about support, not just punishment.
Okay, so screening, assessment, then diagnosis.
Right. Based on all that data, you identify nursing diagnoses. What are the actual or potential problems? You prioritize based on safety first. Common ones might be risk for suicide, ineffective coping, risk for injury, imbalanced nutrition, self-neglect, maybe dysfunctional family processes.
Then setting goals.
Exactly. Outcomes identification. What do we want to achieve with this patient? Short-term goals might be safe withdrawal, managing cravings. Longer-term could be sustained abstinence, improved coping, rebuilding relationships, engaging in a recovery lifestyle. Goals have to be collaborative and realistic for the patient.
Which leads to planning.
Planning. Developing that individualized, patient-centered treatment plan. It considers their goals, their stage of change, their resources.
And then implementation, the doing part.
Yes. Implementation. This involves various interventions, psychosocial interventions. Promoting safety is always number one. Ensuring adequate sleep, nutrition people using often neglect basic needs. Encouraging self-care activities helps rebuild self-esteem. Building that therapeutic relationship is huge, creating a space to explore thoughts, feelings, triggers, develop new coping skills, set small, achievable goals.
What about medications during this phase?
That falls under psychobiological interventions. Administering prescribed meds for withdrawal or craving management, and closely monitoring vital signs and withdrawal symptoms using tools like the CIWA scale for alcohol. You want to stay ahead of withdrawal, keep the patient safe and as comfortable as possible. We talked about some specific meds earlier, like disulfiram antabuse for alcohol, which causes a bad reaction if they drink. Naltrexone helps reduce cravings for alcohol and opioids, acamprosate for alcohol cravings, and benzodiazepines like lorazepam, Ativan, or chlordiazepoxide Librium are mainstays for preventing seizures during alcohol withdrawal.
Teaching is a big part too, I imagine.
Huge. Health teaching and health promotion. Especially given the genetic links, prevention is key. Teaching about addiction as a brain disease helps reduce stigma. Teaching healthy coping mechanisms, stress management, assertiveness skills, exploring the role of trauma if relevant.
And what about advanced practice roles?
Advanced practice nurses often use specific psychotherapies. Cognitive behavioral therapy, CBT, helps patients identify triggers, challenge those automatic negative thoughts related to use, and develop skills to manage cravings. Motivational interviewing, MI, is another big one. It's very patient-centered, non-confrontational. It helps patients explore their own ambivalence about change and strengthen their internal motivation to move forward, guiding them through those stages of change: pre-contemplation, contemplation, preparation, action, maintenance.
And the final step of the nursing process.
Evaluation. It's ongoing. Are the interventions working? Is the patient making progress towards their goals? Do we need to adjust the plan? Keeping it dynamic and always patient-focused.
That framework makes sense. Can we make it even more real with that clinical example from Varkarolus? Mr. Stewart.
Sure. Mr. Stewart, 49 years old, comes to the ER. He's scared, thinks he's having a stroke. His right hand is limp, numb fingertips. He looks older than his age, ruddy face. Says he took a nap, woke up like this.
Okay.
Diagnosis turns out to be radial nerve palsy, Saturday night palsy. He likely passed out drunk on his arm, compressing the nerve. His blood alcohol level was 0.31 milli-GDL. That's over 3 times the legal limit in most places.
Wow. But here's the clinical pearl, right?
Exactly. Despite that very high BOL, he was alert, oriented, not slurring his speech much. That disconnect, that lack of expected impairment at such a high level, that's a classic sign of tolerance. It screams physical dependence addiction.
And the nurse's role.
The nurse, Mrs. Winkler in the example, approaches it non-judgmentally, sees alcoholism as a treatable disease. She doesn't take responsibility for his choices, but focuses on the consequences and potential for change. His priority nursing diagnosis becomes ineffective coping related to alcohol use.
So the plan.
Help him connect the dots. Acknowledge the consequences, like maybe he admits he can't find work because he's drinking. Get him to commit to strategies for control, like maybe agreeing to try an Alcoholics Anonymous A meeting and involving his wife, perhaps suggesting Al-Anon for her. It's holistic, addresses the physical complication, the nerve palsy, the underlying addiction, and the family system.
That really ties it all together. So once someone like Mr. Stewart starts treatment, what does that continuum of care look like? Where might they go after the hospital?
Recovery is definitely a journey, not a single event. It often starts with detoxification or withdrawal management. This is usually inpatient, medically supervised, especially vital for alcohol, sedatives, opioids, where withdrawal can be dangerous. The goal is safe removal of the substance. Then often rehabilitation can be short-term residential, focused on relearning skills lost to addiction, or longer-term, learning new coping and life skills. After that, you might have halfway houses. These offer structured, substance-free group living, helping people transition back to independent living while solidifying recovery goals. There are also things like three-quarter-way houses, therapeutic communities offering even longer-term structured support.
Are there less intensive options?
Yes. Partial hospitalization programs, PHPs, are intensive, structured outpatient programs, usually several hours a day, several days a week. Intensive outpatient programs, IOPs, are similar, maybe fewer hours or days. And then standard outpatient treatment, which could be weekly individual therapy, group therapy, or both.
And support groups fit in here somewhere.
Absolutely critical for long-term recovery for many people. Alcoholics Anonymous AA is the original 12-step program. Peer support, shared experience, working the steps towards sobriety. The model is used for countless other addictions, Narcotics Anonymous, NA, Cocaine Anonymous, CA, etc. And importantly, there are groups for families too, like Al-Anon for adult family members and friends, and Alateen for teenagers affected by someone else's drinking. These provide invaluable support and understanding.
Okay, last big piece, relapse prevention. How do we address that? It happens.
It does. Relapse is often considered a characteristic part of the chronic disease of addiction, not a sign of failure or a lack of willpower. Prevention is key. It involves helping patients identify their personal triggers, people, places, feelings, learning coping skills to manage those triggers before they lead to use, developing healthy stress management techniques, building a strong support network. And sometimes technology helps now too, apps that help track moods or cravings, providing real-time support or alerts.
Wow. Okay, that was incredibly thorough. We've gone from the basic definitions in brain science all the way through specific substances, the nursing process in action, clinical examples, the care continuum. It's clear just how vital and how complex this area is for nurses.
It really is. And the core message, I think, is remembering these are brain diseases, not moral failings. Our role as nurses is comprehensive, patient-centered care, recognizing all the factors, biological, psychological, social, managing withdrawal safely, supporting long-term recovery, understanding comorbidity. It's all part of it.
And maybe the biggest takeaway for everyone listening, especially future nurses, is that point about self-assessment, really thinking about our own feelings or potential biases. How does that impact the care we give? Being aware lets us approach every single patient with the empathy, the non-judgment, and the hope they really need and deserve. It's not just about building knowledge, it's about building that deep empathy.
Which leads to maybe a final thought for you to consider. We talked about that link between early non-medical use of prescription opioids and later heroin use, especially in young teens. Knowing that risk, what specific practical strategies could you, in your future nursing practice, implement to help families safeguard those medications? How can you be a real advocate for prevention right there at the source?
Something to definitely think about. Because that ability to care without judgment, to understand the real complexity of addiction, that's going to be one of your most powerful tools as a mental health professional.
Well said. Thanks for diving deep with us today.
We'll see you on the next Deep Dive.